Okay, so Mrs. X, as mysterious as she gets. 39-year-old prima gravida who has a past medical history of rheumatoid arthritis for which she's had bilateral hip replacement. So when she was seen in clinic, she was actually booked for elective section at 39 weeks for her hips because that was the decision that they made. Okay. She's now coming to our triage at 37. We're on the night shift and she's coming at around 10 p.m. at 37 weeks. Okay. So the first thing this is the handover that you got from the midwives in triage, and we're about to see her now. What would you like? You have the notes in your hand. What would you like to look at?
If she's on any medication?
Before that?
Yeah, that too.
Yeah. So books in time, booking scans, dating scans, all normal. Growth scans at 29 weeks because we suspected small for dates and she's normal growth rates. And then we decide, okay, she looks bigger than what we thought and she's still normal. And then we're doing a follow-up, still normal. We look at her previous notes. She's not on any medication, by the way. She's not on any medication for rheumatoid arthritis. We're looking through her history. So she presented once at 32 weeks with shortness of breath and investigated for no evidence of PE. And then at 35+6, she presents with raised blood pressure and she's now diagnosed with PIH, but no treatment required. She's just for follow-up. And she's referred to the community midwife for the raised blood pressure. And that's when she gets referred again to the day assessment unit. Now, from a little bit later in the notes, you can see that she actually presented the day before and she had headaches and raised blood pressure. Okay. And she was admitted for blood pressure monitoring. And she starts on Levital and she gets steroids because we're thinking, okay, we're going to be sectioning her earlier. Maybe we give her the steroids. And she then gets discharged the next day after her blood pressure is better controlled. Okay. Do we need to look at anything else? Have I lost everyone?
You want to look at the CTG?
So previous CTGs. Okay. So I look at the 33-week one when she came in with a query PE. Happy with that's the comment. Okay. So not contracting based on 145, variability, good, accelerations, no decelerations. When she's still being investigated for her PE, she gets the CTG the next day, pretty much the same. When she's seen at 33 weeks, that's her CTG. Okay. When she comes back at 35+6 for the growth scan, that's the CTG. Happy? She then
you can see that the baseline's going up.
Yeah, you can see that the baseline seems to be going up. Okay. Does that make, why would that happen though?
Because it should be the other way. If you said Levitalol.
She hasn't started Levitalol yet. She starts Levitalol at 36+6.
Oh, sorry. Okay. Okay.
Why do you think the baseline is going up?
I don't know.
Let's park that question for a moment and let's answer it a little bit later. Okay. This is when she's seen at 36+6. So the day before, she comes in and they say that her blood pressure is now raised. Okay. And they start her on Levitalol. But this is her CTG at the time. And the comment that is made is, it's normal, but this baby has a high baseline. Okay. So interestingly, the morning of, so we're seeing her at 10 o'clock at night. The morning of, before she goes home, the comment that was made normal, but baseline has always been 160, hence she's safe to be discharged home. Okay. We're about to go and look at her trace now. Yeah? Anyone have any comments before we go ahead?
I don't have any comments at this point.
Okay, so this is the CTG right now. Anyone want to describe it?
So the baseline is 1. Okay, so we'll start from the beginning. Do you want me to do the whole thing? No?
Yeah.
So defined risks are reduced fetal movements, PIH, background of rheumatoid, not maybe some tightenings, 1 in 10, don't know if they're palpable or not. Baseline is 160. Variability is between 5 and 10. I won't say that there's any accelerations, no decelerations. So I'm suspicious.
You're suspicious.
Hmm.
Okay, so what would you like to do?
Continue the trace for a bit longer.
Okay, there you go. Jenny, would you like to assess?
Me?
Yeah.
Yeah, I would like to assess. I don't know, is it like a hypoxic trace because she's had this raise in 140 to 160 and she's got blood pressure problems? I don't know, don't ask me. This.
How would you describe the trace?
Well, if there are no signs of an infection, is this a gradually evolving hypoxia? I don't know.
Just describe the trace. Don't make the diagnosis. Let us all make the diagnosis together. So the baseline is now 160 still. Are we happy about the variability?
I'm not, but I don't know what normal variability should. I don't know. It doesn't look nice to me, but I don't know.
So usually between 5 and 25.
Yeah.
Fatima was not happy about it here. She was saying, yeah, okay, maybe just more than 5, that there's no accelerations. Okay, Fatima, are you happier now with the trace, or do you want to keep it going on for longer?
No, so I think I'm getting less happy because actually the variability is looking worse and there's no cycling and there are no accelerations.
Okay. So what would you like to do?
So I'm suspecting chronic hypoxia.
You're suspecting chronic hypoxia. Okay. What would you like to do about that?
I would get a second opinion.
Okay.
I 100% agree. Ahmed, come fix it.
Yeah, that's exactly what I'm thinking.
So the team also suspected chronic hypoxia. So they said, okay, well, the risk, she's coming with reduced fetal movements. There are no proper contractions, none that they could palpate, although there were potentially some tightenings there. The baseline was 165. Variability is less than 5 with no cycling. There are no accelerations, no decelerations. So they're suspicious of chronic hypoxia. That was the review by the junior registrar. So the trace carries on because they're now escalating it a little bit further up. And Vanessa, you're obviously the fetal wellbeing team. You're there to support. What do you think?
I think she's not fit for labour.
She's not
So
in
I
labor.
think we need, no, so don't induce her, as in lever. But I think I need to go back a bit, but there's definitely no cycling.
How far back do you need to go?
I just need to see it again. So to me, the initial, some of that, the initial one, some of the variability is 5, not that one. And then what looks like accelerations is actually shouldering, and there definitely isn't any cycling. I don't think it's anything to do with the drug she's on, because we've established what labetalol would do, because she's had labetalol now, hasn't she?
Yeah.
And if there's still no fetal movements and no change, I just personally, I think she should have a cesarean. But maybe not right this minute. You know, it's not urgent, as in Cat 1.
Okay.
But I would, because you can't induce her, you can't leave her. You either wait and watch more, but what's going to change? Don't know.
Okay.
I'd tell Ahmed.
So, well, I'm the non-helpful locum who's come on, and I need you to advise me. So, would you like to wait a bit longer? Would you like to deliver her now? Would you like to give her any medication? She's not really contracting, and this is the trace that you can see.
She's not contracting. There's no point in giving her totalytic.
Okay.
And her blood pressure is all normal.
Okay. So if we deliver her right now, what do we
Yeah.
expect the outcome is going to be like?
So you might have, if you thought it was a chronic hypoxia, you might have normalish blood gases, maybe low Apgars.
Okay.
And the outcome, I think it's so dependable.
Okay. So dependable upon what?
Dependable, but you know, how many times have we delivered chronic babies which we thought have got a chronic hypoxia and they come out kicking and screaming, and others that come out then start fitting, and others that come out and need full resuscitation. I think it's a really hard call to do the, you know, to inform the parents on what the outcome is going to be until it's actually delivered.
Okay. Yes, that's a very important point. The problem, the issue is that you can see signs of chronic hypoxia. You're trying now to figure out, okay, how am I going to deliver her? I'm not happy to induce her. This baby's not fit for labor. Do I need to deliver this baby right now? Okay. The baby's now coming with reduced fetal movements tonight. She had, after she started on other medications as well. And despite her being on labetalol, the baby's heart rate is actually fast. So it's faster than previously. The decision that was made by the team at the time was actually, no, this is pathological. This is prolonged reduced variability. There's no accelerations. There's no decelerations, basically no responses. Hence, this is a chronic hypoxia. Let's deliver her now. And the answer was, okay, let's get an urgent category 2. So it's not a category 1. We're not crashing, but we're doing a category 2. And the idea is to be able to control your anesthetic process, because what we give for most of our women for a cesarean section is usually a spinal, no?
Yeah.
But the spinal causes profound hypotension. With a baby that has chronic hypoxia, this can easily be pushed over to decompensate quite quickly. So the reality is it took about 35 minutes to deliver this baby after having a spinal shot. The Apgars were 0 when it came out, but picked up quite quickly. And as you correctly said, Vanessa, the gases were not bad, because, well, this baby has had, what, half an hour of some hypoxia that pushed its Apgars down to 0. But it didn't have the time to actually make that much of a drop in gases. Does that make sense? It wasn't subjected to acute hypoxia as such, but just about the relaxation and that bit of hypotension before it started delivering just brought it down to almost not responding. Yeah. But once it was oxygenated again and resuscitated, it picked up quite quickly. Does that make sense?
Mm-hmm.
Can I ask you, can you hear me?
Yeah.
I seem to have lost everyone. Oh, so when we do a you know, a nice steady Cat 2 section for a chronic hypoxia, do you think it's a good idea to make sure the women, you know, have proper fluids before we start the spinal?
Yes.
You know how we often do a spinal, we don't fill them up.
So
Do you
it's
think
different. It's different when we're dealing with this, because this is a lady that hypotension can damage this baby. So in opposition to most of the cesarean sections, I would ask for this lady to have her spinal in lateral rather than sitting up. Okay.
Yeah.
I would ask for her to have the fluid pushed in before she starts so that we don't end up with the hypotension. I would make sure that the anesthetist is not in a rush, because the Cat 1s that they need to get us to operate upon, they give a higher dose for the spinal to make sure that she has a good block running in time. Okay. Potentially even give her an epidural rather than spinal. Okay, because it doesn't cause as much of a hypotension. That kind of chat with the anesthetist. I'm not the anesthetist here. I'm not going to be making anesthetic decisions, but it's important to voice that, because this is not on the anesthetist's mind when they're getting to do the section. He or she is just being told, I need an urgent section. Okay, how urgent? I need this baby out within the next 30 minutes or so. But I need to also highlight to them, be cautious, because this lady, hypotension with this lady can damage this baby. The anesthetist would not be thinking down those lines unless we highlight it to them. Does that make sense?
Yeah.
Fatima, you're saying something?
Oh, I was just going to ask, this is a really possibly a stupid question, but do we ever delay, is there any reason to delay delivering for steroids in chronic hypoxia?
So obviously it depends upon what's going on, but if you look back at this trace, this baby, I mean, I was hoping that this baby would have shown any signs of its cycling or doing anything. Now, going back on the traces in the past, so this baby starts off with a baseline of 145, and then the baseline is actually going up. Okay. Chronic hypoxia, similar to gradually evolving hypoxia, the first response is adrenaline. And what happens with the baby is that there's a higher baseline of adrenaline circulating at all times. And the other thing that was interesting is that from 35 weeks onwards, look at the accelerations. There are no accelerations from 36 weeks plus 6, 37, okay, and now 37 at night. There's no accelerations on the trace at all.
Yeah.
This baby's not responding. This baby's not responding at all. This baby's not just not cycling, it's literally not showing any adequate responses anymore. So this is the baby that I would think of, oh, actually, does your baby already have an element of brain injury?
Okay, fine. So there's no point in that case.
Yeah.
Ahmed, why did you say there was only 30 minutes of hypoxia?
Did I say 30 minutes? When did I say 30 minutes?
That's what I thought you said.
No, I said 30 minutes between we making the decision. So if she's having this, she gets the spinal between, so the decision is made at 1:10. She's delivered 35 minutes later.
Yeah.
So this is when she's getting her spinal, etc. We don't actually have trace at that point.
Okay.
So I'm assuming that if she has the 30 minutes of the spinal.
Yeah. Okay.
Yeah. I think that's it for the case.